quick, word about language. If we could actually talk about this for an hour. However, language is fluid. There's lots of terms and lots of ways of respectfully, identifying the population that we work with, us. And we will use TGNC, Transgender and Gender Nonconforming, which is something that I think academically especially, that has been one of the terms that we've been using, and then trans care, but we do want to use it as an umbrella term. Even if we say umbrella term, we are probably excluding folks, who we don't reach. So I just want to acknowledge that. And then, there's no typical gender narrative. So although sometimes, when we're talking about systems especially and what's needed and what's not, we may lift up like medical interventions, or we may lift up like name changes. But there's also lots of trans students who do not transition in a way that we're going to be able to reach them with these systems, right? So just understanding and acknowledging that there's no one typical gender narrative, and that we'll be probably lifting up some of them, and yet it's much more expansive, right? And the research is growing. We're all learning. So the folks who are in the room who have been very much involved in the trans care, we're still very much learning, because it's not just the UCs, it's not just colleges, campuses, it's the country, it's the world, right? Where we're all trying to understand and better serve this population. Okay. Anything else? Okay. And then the background. Do you want to do that?
Sure, yeah. So as I mentioned, my colleague Laura, she is the leader of the trans care team at UC Berkeley, and one thing that we noticed in our conversations is she really wanted to know, how do we work together, right, across all the UCs, really noting how we would kind of consult with each other, really try to reach out to share resources, materials. It's really thinking tank, and really wanting to see, is there a way that we can all get together and communicate so that we're all working together and not in silos, in isolation. So this UC-wide listserv was kind of enacted last year, April 2018. Throughout this past year that we've been active, kind of going over kind of different protocols for the different centers, the different ways that the universities, how their teams are constructed, what are the ways that we are approaching letter writing, just really hearing and putting all the different universities in a kind of continuum of kind of access and understanding what we can do to support each other and navigating through that. How do we kind of navigate our students and clients, their names, chosen names, native names, notifications, ways that we can communicate with pharmacy, interdepartmental communication, and then of course a big one talking about the binary gender terminology and medical forms, electronic medical systems, and then a pretty big one for all of us, right, is how do we navigate insurance? So these are just a few of the different topics that we've been discussing collectively together over the past year. And our goal is working together that we can all kind of navigate this as a collective team.
Do some of you want to come in a little further? There's some seating if that's available to you, or standing room over here. Yeah? Okay, thank you.
Seating meaning the floor.
Yeah. Yes, I'm sorry, that's what I meant. Sorry. Yeah, okay. I just put this up as a way to remind us. This is our latest, at least for us. Where's Elvira?
Here I am.
There you are, thank you. Elvira is our SHIP insurance expert and has provided us really diligently every time, whenever there are changes in SHIP for transgender care, to disseminate this, right? And dissemination actually is a problem. I remember on the call, I mentioned that there were new benefits, trans care benefits under SHIP, and several other people were like, oh, we didn't know this. Can you send that out, right? So dissemination ends up being one of the issues that we could talk about. But this has expanded over the last 5 years, like incredibly, really, and it still needs more. We'll see. So let me just cover this. There's still more that we need, right? And what's not covered is not what's not considered medically necessary. And yet some of these things were on that other list and has now gotten on this list, right? So for example, trachea shave, electrolysis, vocal training were not on the list as of just 6 months ago. Mm-hmm. Yes.
And my understanding is that UC Berkeley
yes.
might have some differences but all the rest of the campuses are essentially the same.
Is that,
Yes, yes.
and is it Santa Cruz as well, or no?
Yeah, we're the same as all the rest.
All the rest of us? Okay, yeah.
So this is new enough that even your medical providers might not know some of these have been added. We were just in the Transcare learning team a couple of days ago, and some of the medical providers were like, no, that's not covered. And I'm like,
Yeah.
I think it's now covered.
Mhm.
So,
It's growing.
yeah.
It's growing and changing. And right now, actually, I'm working on the fertility preservation, and I'm trying to ask Anthem Blue Cross to pay the higher benefits for cryobank students that need to preserve their sperm and their eggs. They want to pay the lower benefit because they're out of network. So now I'm gathering letters so I can have support, so I can ask Anthem to pay the higher benefit because I'm not finding other providers. They've given me one provider that I'm not happy with, and I'm not going to share it with the students because I don't like it. So the one that I do like is it's nationwide, and the students, when they leave UCLA, they're still using cryobank when they're in New York, and they're going to be doing and paying monthly for this storage. I'm working on that. So it's growing. It's growing massively, quickly for Anthem.
I just realized I'm missing my scribe. Sid Jordan, who is a PhD student at UCLA, but also part of our trans team, they couldn't come today, but they were going to be the scribe because we're going to have things like this that we're actually going to want to work on next. So could somebody volunteer here to take some notes? Thank you so much, Kate. Thank you. Or you can record as whatever you'd like. Yeah. I mean, I hope it's okay. We are being recorded as well, so we could use this. Okay, fine. There we go. There we go. Never mind, Kate. Okay. All right. What's not covered? And then this is the chart that Laura Ali from Berkeley also started for us. Now this, again, like for some of you who are from these institutions, you may look and be like, wait a minute, it's inaccurate. Because we all update it as best we can. We go in there in our Google Doc, shared Google Doc, and update it. So it may not be the most, but most of them did say March 2019 was the last updates that they had put up. Any inaccuracies here that you would like to correct, first of all? Yeah.
Well, UCSD has an insurance coordinator, and I wasn't sure if we were talking about insurance coordinator in that next to last column, or if we were talking about somebody at student health maybe that is helping to coordinate care more from a clinical side.
Right.
So,
Kate, do you want to tell them what your role is? Because you are our clinical coordinator.
Yes, sure. So it's a little bit of both of those things, for sure. But yeah, as a clinical coordinator, it's working in general, linking students who are getting their medical care with resources, whether it's on campus or in the community. And then we've sort of developed a specialization with our trans population in terms of navigating things like, letters and insurance, certainly working very closely with LVR, and, navigating issues within following up their appointments, specialists, and surgery consult, but then issues as well.
so are you in the SHIP office?
I am in the student health center, but not in the SHIP office.
Okay, so that's a little different than what we had at UCSD. then.
Yeah.
It's kind of like a case, as you look your campus as case managers, which is.
That's right.
Oh, okay.
And Kate sits with us in the HIPAA protected consultations
Okay.
as well, which is different from an
Yeah.
insurance coordinator. Yeah.
Yeah, she's been down on the clinical floor right next door to me.
Yes.
Okay, I want that.
Absolutely.
Yes.
Yes.
So how do we get on this listserv so that I can comment that Davis does the name change letters, but we do not have a clinical coordinator?
Absolutely. You just please come talk to us, and we'll put you on that list, and Laura will put you on that listserv and on the Google Doc form, etc. Yeah, absolutely. We're so happy you're here. Okay. Anything else? Yes.
A quick question, and pardon my ignorance with this, but are you talking about surgery letters relative to excuse from class, like a type of accommodation, or what is that? I'm from the disabilities office.
Yeah,
No, of course.
like a gender affirmation surgery.
Ah, okay.
Yeah. So WPATH. I never know how to say it. World Professional. What do they stand for? Thank you, Transgender Health. WPATH, it's always WPATH for me. They do the standards of care, and they continue to require letters for surgeries. So it's controversial, I would say, much of the time, and many advocates are trying to undo that because we want to support self-determination. However, it is still standard practice. It's actually a best practice put in by WPATH that we write 2 letters for bottom surgeries and 1 letter for top surgeries. Or actually, the top surgery WPATH I thought had taken out the letters. Is it still one?
Still a letter.
Okay.
And providers can have their own standard,
Correct.
so they might have a higher requirement for letters or amount of therapy or things like that before people are allowed to go into their practice and do some of their transitioning.
Absolutely. So I've seen, I think several of us have probably seen this, that it's at the insurance level there's differences. They don't all follow WPATH. And then at the provider level, the surgeons and the medical providers. And then even within our letter writing, we have different criteria sometimes. And when somebody ends up with somebody who does not, who has higher, requirements for what is that called? Reasonably well-controlled mental health issues, right? There's all of these requirements, like all of that can vary widely. So the students really are having trouble with what is it that is really required, right? And how can I meet this criteria?
The number of hurdles is very high.
Yes.
And I think most of our students can't even get through all of those hurdles in the time that they're in school.
Absolutely.
So oftentimes, students need letters. Maybe they've seen me, for example, and they want a second letter, but it's maybe a year or 2 after they've even been seeing me, because they're now graduated, so it's quite a long trek.
Yes. Yeah, absolutely.
Is there a need to standardize the requirements for that, do you think?
It's actually something that we've been working on. I feel like we've been talking about how do we, recognizing that, as Throme is saying, we have different ways that we approach it, and we've been noting that. I know within my committee team at Berkeley, we've been reviewing different samples of types of letters to see how can we kind of standardize what this looks like. Right now, Laura had created a standardized kind of template of like a checklist of what it must include, and then now we're also kind of figuring out how much more do we need outside of that. But it helps us as the clinicians really streamline that process. So I think we are moving towards that, figuring out a way to
even
make that work.
sometimes providers will come back and
Yeah.
say, "Oh no, you didn't write the things that I need in the letter."
Yeah.
Yes,
so
it's
sort
true.
of the
Checklist,
surgeons,
yeah.
Right, yeah. But the standardization also could and should happen with insurance providers in the network and us, right? So it's a much bigger standardization that would really help our students. Okay.
Maybe one more comment about this
Yeah.
is that you can see that there's a difference on the hormones. So some of the campuses require a letter from a clinician before the student can start on a hormone replacement therapy. And you can see it's sort of moving in the direction on here of just having informed consent. And that, I think, is the push. And our students are sometimes upset at UCSD when they have to come to me and get a letter. They're like, why can't I just make that decision for myself? So I think we're moving in that direction, but you can see we're still.
And I would say that's the same at Irvine. I think our medical provider does not feel comfortable making a decision about the reasonably well-controlled mental health issues. And so maybe as she develops, or Laura, Allie has suggested we consider this kind of a developmental process, and that our goal is to move towards informed consent model, but we need to get the provider confidence all around.
And I think in the meantime, I'm also at Irvine, and I got to do a letter for an individual this year, and just making that process as easy as possible and explaining why we do it, knowing like, yes, your frustration is valid, but like, I'm gonna do a 1-session assessment, and that's gonna be enough for me to write a letter. Like, I'm not gonna make this a whole involved process and do an MMPI, it's not necessary.
Right.
One session, 1 paragraph, documentation.
Yes. And UCLA we were not informed consent as of like a few months ago, and we tried to, and it was not only the providers, but it was mostly risk management, and conversations at that level. But we tried to lower barriers by having like a drop-in person at the LGBT center where people could go, because or else you're waiting for your first intake, which can take a long time too, right? So so there are ways to try to lower the barriers.
And then the UCLA situation is kind of unique because I'm the only one who does the medical nurse practitioner, so if I was a physician, I could just decide I'm gonna do this, I'm comfortable with it, but I technically work in association with physician, and I have to go off-site, I have a partnership with Dr. Weimer, who Jess works for, to have that oversight of someone whose knowledge base exceeds or equals mine. And so our situation was a little more complicated, it wasn't a decision I could just make on my own because of how UCLA interprets how a nurse practitioner works. So some of you won't have those barriers and some of you will. And
Yeah, those barriers are going to be very different. I mean, UCI, I read in our notes that UCI is actually because UCI Med practices this way, and so they cannot move away from, go into informed consent until UCI Med also moves into informed consent. Anyone can verify that?
So the student health physician.
Okay, yeah.
That's who wants the letter right now.
Yeah. Okay.
so you have medical center providers who do the diploma here, or
So we have UCI Medical Center is different than our campus. So we have someone in the student health center who will do it, but she wants the letter.
Can I comment on that bit from UC Riverside?
Yes.
We have medical providers who are on our trans task force, and they are referring students off campus to our UCR Health endocrinology in the community, who is the person that is referring for letters. So it's kind of a two-part referral process. This primary barrier that came up in the last task force meeting with either increasing medical providers' competence and comfort, or increasing, or at the same time needing more space to see more patients in general. So space was identified as the #1 barrier at UCR, space in the student health center. Because we're already seeing tens more than we are supposed to see per day with our small building and small capacity. And I'm just wondering if that's been an issue at any other campus to overcome that first barrier of seeing the ability to see more patients in a small health center without having to wait 5-10 years to build a new health center.
Right. Our students don't have that.
No,
They don't.
Yeah.
You got a 2-year maybe journey with them.
And the whole number is not that great. I mean, it depends a little bit on the campus. You can kind of see the number that we know of, you know, on that second column that have accessed student health services, or the student health center at a few of the campuses. So generally the percentage of the overall student body is maybe, at UCSD it's about 1%. So I don't know, maybe it looks like it might be a little higher at some of the other campuses. But.
and there's the question of which specialty to choose if we're going to increase the capacity to see more patients. Is it going to be diabetes specialists, or eating disorder, or transgender care? It's as if we're not able to pick, so we just don't do any right now until we have the building. So if there's any other, go ahead.
well, do you have somebody on your staff who's interested in getting trained?
Working on that.
Yeah, I mean, it doesn't need to be in the realm, as Will both said, I mean, it doesn't need to be in the realm of endocrine specialties.
Yes.
I mean, it can be done, you know, by a well-trained nurse practitioner who's educated herself with numerous
Yes.
conferences. It can be
Okay.
done by physicians who are family practice, internal medicine. But the place does have to have a commitment. Like my first visits and Amy's first visits are double slot visits. Sometimes the first follow-up is. So I do see probably less patients than some of my colleagues because these are more intense visits. And although my current caseload is about 80 patients, it's been 100 over the last few years, they certainly take a disproportionate amount of time early on. And then, you know, transfer students already on hormones, that's not a big deal. But, you know, so the university has definitely made a commitment to give a little bit more to this population because it's needed. So,
I hear you. You're working on that bit of it.
yeah.
So we're still fishing that.
Yeah,
Yeah.
again, I think the first barrier that we were given when we were raising the question was like, well, we really don't have the space, so we can't really begin to address this. So we're like, I mean, I get the fact that we need, you know, private rooms in order to make the assessment, so just curious what ideas there might be around about how to circumvent or address that main barrier that's been identified.
But I think what I'll add for UC Riverside is that Space is one issue, but it's also the providers not wanting to do that, because some of our primary care, they don't feel comfortable because they don't feel like they have the training or expertise to be doing that, and so that's another barrier as well, as how do we convince some of our providers to say, okay, well, if you're interested, can we get training, and so that's another issue as well.
Yes, and during the task force meeting that we had at UCR with the primary care team, including Dr. Hahn and our director, the medical director, the main barrier that they identified right now was space, because they were basically saying that they were willing to gain the competence and all of that, but the thing that's holding people back right now is there's not even space. Which is why we're trying to figure out how can we address that to then get on to the next stage. Let's build a competence.
Yes, I'm from Davis, I'm a provider who does hormone therapy, but what do you mean by space? Do you mean like for counseling or like,
No, for
like
the
exam rooms?
exam rooms.
I mean, like we put it in, so it was our executive director, Dr. Pamela, who was like, has been providing trans healthcare for like 30 years or something like that, and then she was like, I'm gonna retire, and who's gonna take on my practice? And so as providers, we all were like, well, you've been doing it for a million years, like what's gonna happen now? And so there were 3 of us that stepped forward that were like, I guess we'll do it because there's obviously a need. And so anyway, we were supported by our admin to go to like one conference, and then she sort of like mentored us through the first year, and she was invited back to do that, which was a great resource. But in terms of like, I'm a primary care provider, I also do eating disorders, LARCs, and trans healthcare. Like that's my like specialties, I guess, in addition to just primary care. And so there is definitely like, I don't have a special space. Like I see all of my patients in my primary care. I do get a little bit of extra time for intakes, and follow-ups as well, but beyond that, it is really just like you need providers to like have an interest and have a little bit of time to go to a conference and do a little bit of extra training, but honestly, it is not rocket science, like, and it helps people so much, and they are so thankful, as everyone in this room knows, who has worked with anybody who is in this population.
Because these students are accessing care anyway. I mean, I'm the primary care provider for about 2/3 of my panel, so they're seeing me for their asthma, they're seeing me for their fractured ankle. I mean, so these are people who are coming in anyway to access care like any student would, so.
But the rest of our providers, I'm sorry, the rest of our providers are like, oh, what is this? Hormone replacement therapy. I'm like, this is really not hard, guys. Like, let's all like try and do this. But they do tend to like siphon into the 3 of us because we have more experience and we just have a higher patient load. So.
On the utility health side, it's the same thing. We've got, I think now 2 family medicine physicians and 2 med peds physicians who have said like this is an area of interest and their expertise we're going to develop. But patients just get referred to them like any other primary care provider, and Amy Weimer, who's the medical director for Better Health, does have like a half day a week where she protects slots for trans patients, just so that way, because she's been established for a long time, she's super booked out, but that helps protect some time for faster access. But again, they're just her regular primary care patients, so patients treat them the way they would do any other appointment. And I think that's also for the other UCLA health providers.
It might be helpful, I think, for our medical staff to also be a part of the conversation with primary care at other centers, because again, my concern is more like sometimes we become overwhelmed already by the amount of work that we have, and we are more keen to seeing the barriers than to seeing how do we work around these barriers. That's why I'm trying to understand better how do we navigate these initial barriers so that we're not like just in limbo waiting for the magical building to be built, right, that allows the space. There are solutions there, we just need to be creative, but there has to be a major commitment, so.
I think as Dr. Hung was saying, yes, there has to be the comfort, the commitment, the motivation, the interest, desire, maybe it's not quite there where it needs to be yet.
Yeah, and I appreciate that in the trans call, several primary care providers have offered to also do mentorship and stuff, so I think that what we need to do is bridge the gap between that part and our primary care team.
I think it's also important to note that in California, we are providing health insurance for these people, so we legally have to provide them care. Trans care is protected.
Yeah.
We can't not provide them care because it's difficult.
Exactly, but so we're trying to figure out how do we address these voice
Right, I mean, sometimes
barriers.
that helps push people, like legally, they are paying for this health insurance, you are obligated to provide care for it.
So that's where it comes to, when we refer to providers when you see our health in the community, and there's one, Dr. Hoda? Yeah.
Yeah, Dr. Hoda is.
Yeah. All right, we're gonna move it so we can reach other points as well. This is a survey that one of our postdoc, Krishna Carey, was able to put together. But this is at the very end of spring quarter. We sent it out. Only a few schools were able to really bring up, give us some data. But at least we have at least a range, right? Like just so we can see what campuses. If they have some data, and data is always complicated because how are we asking this question? Are they self-identifying? Are they saying prefer not to answer? Are they in treatment and then they let us know because things have happened and changed? So it's you'll see how I try to capture it in all these different ways, and then what kind of care coordination exists on each campus. And the resources, the wider resources on campus as well was asked. And then I'll go back to this, but I also want to show you that there's two more, just didn't all fit in. Two more of these. One was, the question was progress, challenges, and support still needed. So we can go through these maybe, and it'll probably reflect a lot of, across campus needs. But just wanted to have everybody just be able to reference this, okay? Really, can I just go to the questions, you think? Yeah. We'll go to this, but really what we wanted to do, we're already doing it, is thinking about what's working, what are the main challenges, what are some workarounds, like you said, right? And we would love at the end of this to have one step, large or small, that your site can identify as a goal in the next year that would improve care for TGNC students. And so if we could all kind of be thinking about that, what is that one thing? And some of that might have to be more systemic advocacy, or it could be within your institution as well, right? And then if we have time, or if people want to learn more about it, we can also talk about the structural role and scope of work in campus committees, because some campuses have campus committees. Some people might want to have more of a campus committee access, right, for more information. Okay, so I'll leave it here. I know I interrupted discussion just so I can do that, so I can ask you to discuss. Any questions even about what's up here? Yeah. Yes.
Actually, a question about something that was on the question side.
Yes.
Testosterone pre-certification, not something I think I've heard of before.
Yes. Winnie?
Oh, so with the SHIP health insurance, just like there's certain medications have to be pre-authorized, like Accutane.
Go by the insurance.
Testosterone. So we have to go in there and answer a set of questions, and it kind of forces providers to almost lie, because to get testosterone authorized by SHIP, you have to say that somebody has a binary identification. To say that they're, it says, they just answer, you have to ask all these questions. Are they doing it? Do they have gender dysphoria? Reasonable question. Are they using it to change physical characteristics? Reasonable question. But then it's kind of asks you if the person has a binary identification. Is this a female to male transgender patient? And you have to put yes, otherwise.
I've never had to do that before.
What?
I'm like, what are you talking about?
How do you not do that?
I don't know.
I mean, we do have the strictest.
I'm like, I just send the prescription down and magically they come back up.
I don't
Yeah.
know, so maybe your pharmacy's doing it for you, or I don't know how you're not doing that, because there were two other people.
Don't tell Chef.
No, I'm not. The rest of us have to.
Cut that out of the video.
I got 2 calls yesterday at the conference because my colleagues were asking me, I'm trying to do this for you, what do I have to write? And then you have to say that the testosterone levels are in the appropriate range. Okay, well, I need to go to Davis, because I do this every, and then you also, of course, have to go on Cures, which is the controlled substance database. So even though I have never had a patient ever abuse testosterone in the entire time I practice, I mean, it may happen, I guess, but so I have to go on Cures and show how often they're getting it, and I have to print that out and scan it into my chart.
That's a UCOP thing, yeah, so
Yeah,
that's
yeah.
like new since like October or something like
So
that.
it's a law, it's a law
Yeah.
that started with the opioid crisis.
This doesn't exist for,
Because
I mean,
it's
I
a-
think,
no, they're
No,
actually,
it's
even
a
though there's
control.
like bigger dangers with overdosing someone on estrogen, we don't have to do anything, you know? But, yeah, so.
But you should look into that, and I will also look into that, but I've never had to fill out any of those things for the testosterone pre-certification.
I have no idea how that could be. Yeah, so we'll sidebar that
Mhm.
because, yeah.
But this is
Jason
helpful.
and your
Well,
Maybe.
we have the most conservative pharmacist on the planet, so we also have to, it's the same thing if somebody over 26 wants to use cream, but for acne, so it's,
Oh, we don't have that
She's just sliding by.
You might, I don't know how she's getting it.
And this is a one area, I think, like if all of the UC campuses were able to
Yes.
follow a standard protocol, then, we wouldn't have these huge differences, because that's like a lot of extra legwork to have to go through.
It's hard to know
Yes.
everyone else is doing that, because the Berkeley people ask me what I was writing. and
so if you
so-
want drugs, go to
Yeah.
David.
Go to We're just like, what do you want? Testosterone?
It's happening to a day.
Can you also edit it out?
They're like, all of a sudden we have these tons of new patients.
We got a beach.
We have cows.
In a room full of providers, I just wanted to go back to one of the first pretty things you said. It said, letter for name and gender change. In the state of California, if your student is a California resident, they don't actually need a letter for name or gender change.
That's what I said, right?
Gender is recent, name is not, but gender is very recent.
Where we are still doing them a lot of the time is, passports, other, national documents.
Yeah.
Mhm.
If they're a California resident, they still don't need it for name, they might need it for gender.
Okay.
We do that on the medical side as well. I don't know if all of your guys' medical providers are doing that, but on my intake appointments, I address that, and then in each subsequent appointment, I'm like, okay, so updates on, are you needing anything for, like, any letters for anything, so.
Now, what else? I mean, the pharmacy reminds me of just there's so many systems within the health system. So even name change or what appears on the screen, if we change it on the CAP side, that doesn't mean that the health center side will have it. The health center side doesn't mean that the pharmacy will have it. It just, we keep finding these because, of course, thank you so much. Village. It's so yeah, we keep finding these because thankfully our students come up and say, hey, so I still get that notification with my dead name, right? Like I still get that, and I'm still getting called this name out loud in the waiting room, right? And so I wanted to lift that up, see what what's going on in the other campuses, but I also wanted to take the opportunity to also say, like, that's why we need so much student representation. It really makes a huge difference because we're seeing it from our side of like what we have and what we don't, but they really can identify it very quickly for us, right? And oftentimes it's in one-on-one in our sessions, and we need to lift that up, right? And that's why these trans committees have been really helpful, because then we can bring all of these, grievances and experiences, and bring them up to see like where can we make these systemic changes.
I just want to put out UCSC, we have a really great IT person, who's like trying to refers to as breaking things all the time. But for CAPS in the health center, if you put name and pronouns in the preferred name section, that it will show up crosswise. And he's also working on putting you, because X is available as a gender marker now, and we have to start doing that. And so it's going to show up as you in testing, like what that comes back as pharmacy. And when people do labs, and there are a few labs that require ranges, so he created it so that for the ones that have ranges that are specific to gender, that it's just on the top of everything, so that the ranges that the lab is going to send you back request is going to be wrong, but the right ones are on every single one, and it's up to medical provider's discretion to do that.
Where does this IT person live, can I ask?
Yeah.
Like, in which department? Is it just
In our
IT?
health center.
In your health center, okay.
I don't work on the CAP side, but I'm familiar with the system, but, and this is unique in San Diego, but I'm wondering if it's gonna impact in any other campuses move this direction. It's probably more pertinent to campuses with medical schools and health systems attached. But UCSD is transitioning CAPS and student health to Epic, which is the health system's medical record system. So I was just thinking about it, it's gonna be a whole different system.
That's right.
But it's also nice because it's integrated with the health system. I'm just wondering if there's been any, like, looks at Epic and what it looks like, because for them, PNC is not gonna be applicable anymore at a certain point, because they're gonna switch.
So Dr. Weimer works on Epic, and I've seen her template, it's very similar to mine, and
Okay.
so she's kind of dealt with every nuance.
Yeah, so the UCLA Health Center, we use Epic, and we've started, you can now, you can list preferred pronouns, you can list preferred name, or, chosen name. And right now, the chosen name shows up in parentheses, and then whatever name is now like legally there, has to show up, because again, that has to coincide legally for insurance purposes. But there's going to be another shift that's happening where there's still going to be that legal name that's included for the insurance purposes, but what's going to actually be the most front-facing name will be the name that they use. Because to again help with appropriately greeting people and acknowledging and using right name and pronouns. So there's shifts that have been happening. Through the health system, and there's a point person at UCLA who's been kind of a main care connect person named Amy Cummings. Who's
They've been doing that also at health
Yeah.
system at UCSD.
Yeah.
So, and also the registrar now at UCSD is taking lived names, and you can update your name and your gender in their system, and that will populate out into some systems right now, like class data for professors, and that way they're not getting dead named in their class and things like that. But it's still, there's still some systems also that won't take the data yet, but they're working on it.
So I don't know if you want to say more about it, but we have both on campus and something through UCLA Gender Health, where if we identify a department that's consistently making students feel unwelcome or uncomfortable, there's interventions. And our LGBT center, or maybe you can talk more about it, will go and do trainings. They're going to train our pharmacy and our lab hopefully sometime this summer, because we've identified those as the two places we keep having problems. But you guys have also innovated and called people in to do trainings. And
Yeah, so I think UCLA is now, we're hoping to kind of begin have mandatory training that is, rolled out to hopefully all health system employees about, just kind of use of name and pronouns and just trans identities or gender diversity, just to help hopefully get everybody more on the same page. So I think that's one thing we're trying to do right now. It's an optional training. We're trying to have it mandatory system-wide. Other things, like we've kind of done maybe a little bit more subtly, but I know like Amy and myself, when we maybe perhaps are reviewing other providers' notes and there's like really inconsistent use of name and pronouns, we've kind of created this nice, there's like smart phrases, so like a little blurb that we've created that will just kind of like round a message to the provider that's like, hey, by the way, this patient actually uses this name and these pronouns, just a really polite way to kind of call them out on the use. And I don't know that I can clearly say that I've noted a change, but we're just trying to comment on it more often. And we've done a lot of training with our front and back office staff as well about, correct use of name, pronouns, and things. And, our
UCR, does anybody have any experience whether Live Health can help us with some of these barriers on the Live Health Online program? Do you have any experience with that at all?
Like prescribing hormones?
I mean, some of, I don't know, because I was reading into their, what they provide. They do provide transgender care, but I don't know of anybody who has first-hand experience, any provider here.
This is the Anthem Blue Cross telemental health.
Yeah, the thing, the caveat is that they don't go through us. They can go get enrolled without any of us being ever involved. So I don't know how does that work out.
Well, what we heard even on one of the calls was that, I don't remember which institution, but they said that a student had gone on Live Health, and already within the first gender options. There was nothing, like it was just binary, which is already a problem, and that person actually just discontinued as soon as they got on. So that's something that I've been trying to lift up to the folks in Life Health. I don't know if anybody else has any.
I believe they have psychiatry services, and anyone else can jump in on this, but I also think that like many online services, they aren't allowed to prescribe any controlled medications, which you heard like testosterone, so
Right. God.
controlled medications. So I don't know the answer to that, but I. Also, I'm not sure about ordering labs and stuff. We did have a similar issue with the ranges coming back, so we would send, because all of our hormone level labs had to be sent to the med center, and so we would send them, and then we would say, in the comments, this is a transgender person, and then they would still send us back labs in the incorrect hormone ranges, and that was a huge issue that took probably 4 years for us to fix, but it's fixed now. That one thing is fixed. And then within Point and Click, one of our struggles is that we're still trying to sift through all of our wellness visits and things like that, because we still have women's health templates and things like that, and so that is, I find new ones all the time where they're very gender specific, templates or macros or phrases or things like that, so that is an ongoing battle for us as well.
What do you call your women's health department?
It used to be called women's health. Now we have sexual health, and then we have, but the gender stuff is not within our sexual health. It can go into that, but then it gets siphoned back to us. And then we also have, LARC clinics, so that's not gender specifics.
Also,
we're
since
trying
we
to
have
think
the
of
insurance
the-
expert here, is that still the rule that if you go 51 plus miles on your campus, you can go to any provider, or no, that's being
For
revoked?
reciprocal care.
Yeah, for anywhere. Yeah, it used to be you can use it as a PPO, you can go to any provider, including transgender care provider. That 51 miles limit still is valid or no?
Level ours.
We
We have
have
no
to-
limits on them. It's not an in-network provider,
Yeah.
that provides gender health.
But if you go out of state, it's blue
Certainly,
card, right?
Out of country,
Out of country.
Alvira, do they still need a referral for that though, or is it in one, yeah?
They still need referral, actually, our referrals, yeah.
But there's just the tiers, right? It's either in the building, in the UCLA system, or if it's outside, it doesn't matter where it is. It could be in 5 minutes from us or 50 minutes from us,
Right.
and it's the same as long as they're Anthem.
Right.
And then if they're out of Anthem, it's even lower.
But, yeah,
So okay, so your specialist is an Anthem provider, or?
I'm just saying that,
Yeah.
because we used to have that rule,
No,
if
yeah,
the
that doesn't
student
matter.
can go to 51 miles away from our campus, they can go to anybody who accepts
Yeah,
it
I know.
without referral.
without a referral.
Yeah.
We need referrals.
Yeah, if it's out of.
Even if it's within, we have people literally a mile away, but have students who said, I don't wanna work with this provider, but they're the provider who provides hormones. We provide a referral for them to see and just put trans specialty care, and then they go see, the person in our community who can do that.
Even if they're 100 miles or out of country, the benefit remains the same. We still need ASH referrals. We just want them to stay in network. Otherwise, they're paying too much. $500 deductible, 40% usual and customary rates, could be 40, could be 60% they're actually paying. So that's what I'm working on, the cryo fertility. I don't want them paying that very benefit, a limited $20,000 benefit for that. So that's why I'm always working with Anthem to grow and to increase the benefits. And it's hard for one person to struggle for our trans students. And just getting support from people helps a lot. And I've made a lot of changes with Anthem because we're learning. This is a new benefit, actually a new benefit for us within 5 years. So this new benefit's growing. Our students are getting used to it, and they're getting used to trusting us. Just having them trust us is a huge thing. So when they come in, I let them know it's very comfortable, it's a safe area for them to come in. They help you navigate. We just need to know what our timeline is. That's my biggest thing. When they come in, how quickly can we help them? How can we find providers? We've got UCLA now, which is great, because we used to send them up to San Francisco. That's a 2-year wait. They're graduated. It's not helping them. So I had to have Anthem Blue Cross expand our providers. They gave us a list of 10 people, and I go, this is useless. You know, we need providers. They're finding good providers in New York. Why can't we do them? So I had them expand that. So I'm just, you know, it's a big benefit. Anthem takes a long time. It's a lot of convincing, but we get our way. We will.
Although I do still have students that are having a 2 or 3 year wait list for surgeries.
Yeah, it's the providers in the area too. We're building more providers, and we'd like them to go to UCLA so we have continuity of care. We know where we're going.
UCLA, I mean, our UCLA, the wait is not that long.
Right.
I've had people have top surgery in 3 months.
It's,
It's amazing.
It's pretty fast.
A lot of my students are having their surgery now.
Well, now in San Diego, we can do top surgery, and what else are we doing?
It's good to know.
I'm blanking on it.
Bottom?
There's a couple. No bottom surgery. We don't have a urologist that can do it. That's sort of like a aspirational goal would be to have a urologist in the health system that could do that.
But you could technically use ours.
Yeah.
Because.
Because we have the same UC, so they
Oh,
can come to ours.
hysterectomies. We're also doing hysterectomies.
Yeah, just to say, I think it depends on what they're being done, it's hysterectomy,
Yeah, so.
We've got OB-GYN doing hysterectomy, oophorectomies. We've got urologists doing vaginoplasty, radioplasty, phalloplasty. We have top surgery, both transmasculine and transfeminine top surgery. We have facial feminization surgeons. We have a cord surgeon, but also speech therapy.
Tracheal shaves, you said the first one. Tracheal shaves.
And they'll coordinate. One of my patients had both their tracheal shave and their breast augmentation done at the same time.
Yeah,
But at the same time.
I do want to note that all of this is pretty new for us. So
Oh, yeah.
as of 2 years ago, we were still, like, we had almost nothing, right?
Yeah.
So
Yeah.
just to I guess build hope, right? That these things are developmental and they do change, and you know, one person in the community can really build a whole lot, right? So I'm sure that there are other campuses where there's not as many resources, but this has really happened for us in the last 2 years, I think.
At UCR, we had a provider in the community who reached out to the Trans Task Force and the LGBT Resource Center offering their services, but they are with the county, and so it's out of network. So we take what we can get out there, they're not in network, it's a huge.
I really want to keep them in network as much as you can.
Yeah, we'd rather just UCLA.
Depending on what they're looking for.
Some of ours are going to see this because UCLA wasn't on board yet, so a lot of them are going to see this.
Well,
We just use this and we'll come
Yeah,
in
people want to know
quickly
how
when
surgery somebody's done.
Ours are newer. Yeah, newer folks.
Yeah, they're newer.
Yeah, Horace, Cedars, this one.
So is there any way we can expand that trans call that we have periodic to more disciplines, so they can, like, on PCPs, they meet together, on call together, insurance from different campuses, they can have that call together, provide the therapists, Because I think that way
It's a
the
great
mentorship
idea.
is more focused.
It's a great idea, yeah.
I'm just wondering too, because I know like for case management, we have a monthly call, so
Right.
maybe having somebody from your team join 1 month, I can help with, putting that on the agenda, and having somebody come in, like we've had somebody come from SHIP and join our call and talk about SHIP, but that might be beneficial. I know I've had providers reach out to me from other campuses asking about transgender care, how to access it, so it would be a good resource, because case managers are managing that. and
Yes.
that.
Look at the
think that'd be great.
interdisciplinary presentation in this room right now, that
Mhm.
testifies.
I think both would be great, because I really actually love that the fact that right now the trans call is interdisciplinary in itself,
Right.
but then from there we need sidebars.
Yeah.
So, because all of these specialties need to be talking with each other a little bit more frequently, perhaps.
Right.
Yeah.
And then on the campus, I think having different meetings is also helpful. Like we have a
Yeah.
Chancellor's Advisory Committee on gender identity and sexual orientation
For the
issues.
name, but-
That's across the whole university. And then we have joint case review that's just with under HIPAA. And then we have a trans care learning team that's got providers in there, but also the LGBT Resource Center, and maybe students come in to that. And so there's different levels, and I think having those different levels is helpful.
Yes.
But before that, before the Transcare Learning, I mean, we've had 2 meetings of our Transcare Learning team, and before that, it felt very siloed. I was like, I mean, I know Kat does Transcare, but we're in different locations, and, you know, to even consult is difficult, so.
We're in the same department.
Yeah. So breaking down those silos, you know, has been really helpful.
And Nancy, can I put you on the spot? As you're on a call with UC directors, right? Like clinical directors. And so at that level as well, and over here as well. And at that level as well, it would be great if you or others, if people are invited to talk about the importance of this kind of time and space, right? Creating more time and space for people to do these interdisciplinary consultations. I have the support at UCLA, right? From CAPS and from you and from Nicole, but a lot of others may not actually have that support quite yet. So
yeah,
you could
it's
lift that up.
certainly the kind of thing that we have discussed in the past. We bring up agenda items based on what we're experiencing challenges with on our campus, and then we all discuss and benefit from the conversation. But it is.
And my sense is our group is pretty supportive of that.
Yeah.
It's the physicians sometimes, like their schedules are so tight, they don't have the time to do that, or it's the partners, I think, that we're having trouble with.
Yeah, one thing I'm thinking about in sitting here as someone who does like one-on-one clinical work mostly is the ways in which academics can start getting involved as people access healthcare. And I was sitting with a student and realized I didn't know if and how to refer them to CAE under like some of the things that they were getting. And so I don't know if that's something we're talking about in here, or if others have kind of navigated that academic side or the accommodation side as people are recovering or as people are struggling.
Kate, you want to address that?
Yeah, certainly on our, right, CAE is our disability office on UCLA's campus, so I think that's a very valid point. And yeah, some things, some surgeries and recovering there, we have colleagues here too who might be able to help, speak to that. But certainly some things, yeah, there's certain forms that may be on your side or maybe on the medical side if it's a surgery, in terms of accommodations they may need. We have a man on campus, right, that can drive folks as well if there's a physical limitation. So, we can connect certainly online about that, but I imagine that probably exists as a barrier on other campuses as well who don't have clinical coordinators or case management folks in that kind of role.
I think we have,
And
go ahead.
campus structure, I can't say case management, we're involved a lot of times with that and helping them with, at UCSD it's OSD, which is that similar office, but we do a lot of that, helping them connect into the academic side, the deans and academic advising and Office for Student with Disabilities. So that's, however that referral happens on your campus, I think that's really helpful for the students. I've had, I think one student in particular that had surgery last summer, did it during the summer, which worked really well because they get the break, but they had complications. And so in the fall we had to make some adjustments we didn't expect to have to do because of the complications. So those people are kind of like plugging my own people, sorry, but those people are
And CAE at UCLA, it might start off with a case manager when they're in the hospital, and then the case manager will refer to us directly. If they are one of our students, like I've had a couple of students that are on that process, I immediately pick it up, and start sending out letters of support for our students. So yes, and I think this is a wonderful work for me to be here because I'm seeing the flip side of it and the tremendous amount of obstacles that our students have to face. So when they come to us, with psychological, issues, it's like, wow. So this has been very, very helpful for me. But yes, we're very, very aware of the psychological impact that they go through, but not the administrative kind of part that I'm seeing here now. So that's always good to know.
Yes, okay, so as we kind of come to a close, right, for our time, just kind of going over some of these recommendations, right, as we're discussing ongoing awareness of our comprehensive needs, coming up with an assessment plan around this, implementation of our next steps, continuing to invest in our ongoing professional development, some of the areas we've discussed here, also including just our general cultural competencies for intersectional approaches to care. And then this has started, right, our best practices guidelines. We're working on creating best practices guidelines for all of us to kind of share and collaborate on. And these are some of our ongoing next steps, and I think
and we have more that we just discussed right now.
Naming all these
right?
other things, yeah.
Yeah. But if you're not already on the call and you're a trans care provider who needs to be on the call, please give us your information.
Come over here.
Come over
Yes.
and give us your information so you can be on that call. And then, this is just the beginning, right? Like, we want to do this more often. I actually think that perhaps in the next UC conference we should have just another discussion, right? Like, I'm sorry? In a bigger room, yes. But we'll.
a bigger room.
It is, yes.
That's what I'm thinking. Is
That's
there's
right.
ideas that we wouldn't be this big, and what does
Yes.
it mean that we are this large?
Yeah.
This is awesome. It's
Yes.
really awesome.
Thank you, everybody, for doing this work.